Good morning. We're going to finish up the PowerPoint on mechanical ventilation. And then we're going to have time to start on the next PowerPoint, which is congenital heart defects. So in talking about mechanical ventilation, what are the indications that we need to place the newborn on a ventilator? And it gives you the signs of respiratory failure. PCO2 greater than 55 to 60 torr. So when the CO2 is 60 torr, expect a pH about 7.24. So let me put that in the chat. Do you remember for every 10 torr drop or 10 torr change in CO2, it changes the pH 0.08. So that's where that number came from. So 7.24 is where the pH would be to say, you know what, this baby is not doing well. We need to intubate them and put them on the ventilator. And this is for your NBRC exam. When you're in the different neonatal ICUs, the criteria might be different. Also, it says a PaO2 less than 50 on oxygen. And please write in your note on 50% or 0.5 FiO2. So if they're requiring more than 50% to oxygenate, that's another indication they need to be on the ventilator. Good morning. Also, if you see an increased work of breathing, so if you see an increased work of breathing, but the blood gases look normal, and it's usually an indication that nasal CPAP will make a difference. But if you place the patient on nasal CPAP and still you see the sternal retractions, the xiphoid retractions, nasal flaring, what are some of our other signs of distress? The grunting, then nasal CPAP is not good enough. They need to be intubated and placed on the ventilator. The next thing it says is depressed level of consciousness. But how can you tell that a neonate has a depressed level of consciousness when they can't communicate? So what you do is you look at their extremities, and if their extremities are limp or flaccid, we assume that their neurostatus is depressed. So limp extremities. By the time you see periods of apnea occurring, gasping breaths, bradycardia, hypotension, that's like right before death. So you probably waited too long to get them intubated and get them on the ventilator. All right, now we'll go through the different modes of ventilation that are used on neonates. It says that infants up to 10 kilograms body weight are usually ventilated with pressure modes of ventilation. 10 kilograms, how many pounds would that be? 42. So 2.2 times 10 or 22 kilograms. That's what, like a year old? Year and a half, maybe 20-pound baby. a 2-year-old. So let's go with a year and a half, you're ventilating with a pressure mode of ventilation. So the pressure modes of ventilation we are used to is the one at the bottom, SIMV-PC, pressure control. And then also have pressure support on for spontaneous breaths. So never think, oh, pressure support is only for adults. We don't use pressure support on infants. That's not true. So anybody intubated, breathing on the ventilator with spontaneous breaths should always have pressure support. Remember that small amounts, like 5 of pressure support, whether it's an adult or an infant, it overcomes the work of breathing, of having an endotracheal tube in and breathing through the ventilator circuit. So you always want to have pressure support set. So SIMV-PC. So we know that the mandated breaths are pressure control breaths. And what we know about pressure control breaths is that they are pressure limited time cycle breaths. And volume varies in pressure control, so we know that. SIMV mode, we know that we've got mandated breaths and spontaneous breaths. And then the mode above that is TCPL. And that stands for time cycled pressure limited breaths. So time cycled pressure limited breaths. That's the same thing as pressure control, right? Mm-hmm. So there's no difference there. So why don't we just call it pressure control? Well, there is a little bit of a difference between pressure control and TCPL. And the difference is the flow waveform. So the normal pressure control, the ventilator delivers a lot of flow to get to the peak pressure at the very beginning of the breath. So it rushes in a big flow of air, pressure gets reached, and then as the air is flowing in, it keeps the pressure constant throughout inspiration. Well, with TCPL, instead of there being a big rush of air, it keeps the flow rate constant throughout inspiration. So that's the only difference. So it tells you here, the flow waveform is constant. And you set the amount of flow during inspiration. So when you're in TCPL, you're going to have a knob for setting your flow. With neonates, so you set flow in time cycle pressure limited mode. And it for the neonates, 5 liters a minute up to 8 liters per minute. And with setting the flow rate, how are you supposed to know that it's enough flow? And let me type that question in the chat. How do you know if you have enough flow set? And the answer is, if you reach peak pressure, then you have enough flow set. So if you reach the expected peak pressure, you have enough flow set. So that's the only difference between regular old pressure control and TCPL. You're still going to have your volumes vary because that's typical of pressure control. On the ventilator, when you set your inspiratory pressure plus your peak, that's how you get your peak pressure. That's the same. So everything's the same. The only difference is you're setting your flow rate. So the question is, why bother? Why not just have pressure control mode? Why do we need TCPL? What's the big deal about having a constant flow waveform? So neonatologists claim that having that rush of flow at the beginning of the breath is uncomfortable for a neonate. And to do away with that fast rush of flow at the beginning of the breath, they prefer constant flow, where you're not getting a big rush of air at the beginning of the breath. So that's what their claim is, and that's why the manufacturer came up with this mode. So what do I type in the chat? Why not just use pressure control? Why TCPL? Or how about how's that? Why bother with a constant flow rate? And the answer is, it's more comfortable for the infant. And then the answer, it claims to be more comfortable for the infant. It avoids a fast rush of air at the beginning of the breath. But in pressure control, could we control that fast rush of air? Yeah, with rise time. So can you tell that I don't really buy into this logic?
No.
Exactly. Did they ask them? Good point. All right, and then volume guarantee came about, and volume guarantee is only available on the Avia ventilator. It's too early, Rachel.
I'm stretching, not yawning.
Okay. Oh,
That's not.
yeah, Tiffany isn't here to fall asleep on me, so figured you were taking over the.
We're also saying that mode, if you have the TCPL VG, it's really similar to PRVC.
Yes.
Turn the flow off.
Yeah, very similar to PRVC. So with PRVC, we know that the inspiratory pressure varies to target a tidal volume. So Avia came up with volume guarantee, and it does the same thing. It varies the inspiratory pressure to target a tidal volume. But of course, the names are proprietary, meaning that like Servo has it branded that PRVC is their term and nobody can use it. So any other manufacturer has to come up with a different name. So Avia came up with volume guarantee. And says the inspiratory pressure will vary to target a tidal volume. And it's combined with other modes of ventilation. So when you're charting, you've got this string of abbreviated letters that you're putting in the chart. So to be in TCPL with volume guarantee, and maybe you are in SIMV TCPL with volume guarantee. So that's a lot of letters. It's like, wait, what a minute. What mode are we in? So if you see volume guarantee, you know that your inspiratory pressures are varying to target a tidal volume. And if it's SIMV mode, you can also have pressure support. So let's make up a string of names here. How about this one? SIMV, TCPL, VG with PS. Do you see why you get paid a lot of money? All right, so going through it, SIMV, we know we're going to have mandated breaths and spontaneous breaths. TCPL, we know that our inspiratory pressures are going to fluctuate to target a tidal volume. No, I said that wrong. That's the VG. TCPL, we know we're giving a pressure control breath with constant flow. And then the VG is our inspiratory pressures will vary to target a tidal volume. It's like PRVC, SIMV, PRVC pretty much. Question, Tidjin?
How can we have volume guarantee and TCPL?
It's actually what I was gonna ask too. Does it?
You start off with your pressure control breaths and having the VG means that the pressure control can vary.
So will it vary only to the max level of what we already had the pressure support set to? Is that where it comes kind of like an alarm limit for PRVC? Or like
Pressure support, you mean pressure control?
Yeah, for TCPL, like you set the pressure. But when you add the VG, you still have the pressure set there, but that's essentially kind of like a high pressure limit alarm. Like
So
PRVC,
you
right?
have your tidal volume set,
Yeah,
not your inspiratory pressure set.
okay, so it changes it over.
Yeah.
Because technically PRVC is kind of like a combined mode almost.
Yeah.
The pressure and the volume, so TCOP and VG cover both of those things.
Yes. Yeah. So you're giving a pressure control breath, but it's varying for the volume.
Is volume guarantee a mode?
It's like an add-on, right?
Because I kind of walked in on maybe not the greatest.
Our ventilator, the Avia that we have here in the lab doesn't have volume guarantee, so you really don't get to see it on the screen. But yes, it is a mode.
I saw it Friday, it was TCPL plus VG. That's what it says.
Oh, does it?
Yeah, it says plus VG. That's what was confusing.
So the mode itself said TCPL plus VG.
That's why I thought it was like an add-on too.
Oh, Tiffany's defending herself. It's too funny. If the delivered tidal volume exceeds 130% of tidal volume, inspiration ends. So the ventilator is monitoring within the breath, which is different than PRVC, where PRVC waits for exhalation to occur and then says, oh, wait a minute, that was too much volume. Let me step down the inspiratory pressure. With this mode of ventilation, if too much volume is going in, inspiration will end and prevent more air from going in. So it's a little more lung protective than just having straight pressure control or having PRVC. Is that self-explanatory? Do I need to put anything in the chat for that? If the delivered tidal volume is too big, inspiration ends. So instead of having a half of a second for inspiration, it might end it at 0.3 seconds to make sure that more volume doesn't get delivered. Is that good? Yeah. A flow sensor has to be used. Do you remember the difference between measuring volumes at the exhalation port versus measuring volumes at the Y?
Was it the dice space?
Is it?
Yeah, so when you're measuring volume at the exhalation port, the volume is two things. It's the volume coming from the lungs plus the volume that stretched the circuit. And it all comes back and you don't know which volume was in the circuit, which volume was in the lungs. So it's not going to be an accurate tidal volume. More accurate is when the flow sensor is in line and it only sees the volume going in and out of the lungs. So in order to have a volume guarantee, it says you have to use the flow sensor to make sure that the volumes are accurate. All right, so those were the modes. Typically, SIMV pressure control. You don't see much PRVC on the neonates. So SIMV pressure control or TCPL with volume guarantee are the two that you see used the most. Next, we get into ventilator settings. So with respiratory rate and a neonate, it leaves it blank. And your starting respiratory rate for a neonate is 40 breaths per minute. Um, 40 breaths per minute is the same rate that we use. Like if we have to ventilate an infant with bag valve mask, we ventilate 40 times a minute. So that's giving them not their maximum rate, but their typical respiratory rate is 40 breaths per minute. When you're weaning them from the ventilator, you wean down to 10 breaths per minute and you don't go any lower than that. And the reason for that is the small endotracheal tube that they're intubated with. There's really high airway resistance trying to breathe through that little tube. So once you get them down to 10 breaths per minute and you're not giving them any more mandated breaths than 10 per minute, it's a lot of work that they have to do on their own. So you're ready to extubate them and put them on nasal CPAP at that point.
Would you say that's a weaning parameter then, or just?
A weaning parameter, it would be like having the adult on SIMV mode and you get the rate down to 4 breaths per minute and then you extubate them. Right, and then with infants through pediatrics, 1 month to 1.5 years, when you put them on the ventilator, you're going to use a slower rate. You're going to use 20 to 30 breaths per minute. For IE ratios, when you have a fast respiratory rate, you want to pay attention to your IE ratios because you could be inducing inverse ratio ventilation unless you're careful about your inspiratory times. So up to 60 breaths a minute we're usually safe because we have an I time of a half of a second. So 60 breaths a minute, a half a second to get the air in, half a second to get the air out, we're good. But any I times over a half of a second, now you're causing inverse ratio ventilation. So I just wrote, for example, a rate of 60 breaths per minute should have an I time of 0.5 seconds or less. Otherwise, air trapping will occur. So if the IE ratio is 1:1, are you okay with that? Yeah, maybe with some BPD babies and the obstructed airways, we would want a longer exhalation time, just like we do with our COPDers on the ventilator. But your typical reasons for being on the ventilator, like RDS, you're okay with a 1:1 IE ratio. 1:2 is better, but 1:1 is acceptable. For peak pressure, it says neonatal lungs are very sensitive to barotrauma and volutrauma. To minimize damage to lung parenchyma, keep the peak pressures less than 25 centimeters of water. And then ideally 18 to 20 centimeters of water. So this is including PEEP. So if you have your a PEEP of 5 centimeters of water, what should your inspiratory pressures be? Like 19?
Yeah.
So if you have 19 plus 5, a peak pressure of 24. Yeah. Yeah, so if you could keep everything, all the total at 20, that means your inspiratory pressure of 15 centimeters of water would be like your upper limits of normal, I guess. So what are you guys seeing in the neonatal ICU as far as peak pressures? You're seeing a peak pressure of 20? Are you? Okay. And who else was in?
Friday,
Nikki.
so I remember nothing over.
Nothing over 25? Rachel, what were you seeing?
Probably averaging around there, but I've seen some that go higher than that, but they were like babies that were sicker, so I mean, it would fluctuate constantly.
I see. Okay. So at least you know what your general goal is. Keep your peak pressures less than 25, preferably 18 to 20. And then you adjust your peak pressure to achieve 4 to 6 mLs per kilogram. Whoops. So I wrote adjust inspiratory pressure to achieve a tidal volume of 4 to 6 mLs per kilogram. So if a baby weighs 1 kilogram, they're 2.2 pounds, they're born at, I don't know, 26 weeks, really premature. They're on the ventilator and you're looking at their exhale tidal volume. What would you expect for that size? 1 kilogram. What would their tidal volume be?
20 ml.
Would it be 20 mLs?
What is he, 4 to 6?
Yeah, so 4 mLs would be the tidal volume, 6 mLs would be the tidal volume. So when you're seeing an exhale tidal volume of 20 mLs, that's including the volume from the circuit. That is not what went into their lungs. So, yeah, seeing 20, 25 mLs, there's no way you can get that much volume into those little tiny preemies.
So that's the circuit.
Yeah.
So is there, okay. Never mind, I'm thinking about circuit compliance then, so. Would that mean that they compensated for that, or,
Who's they?
you know how you do the pre-check on the, right? And you press yes for the circuit to account for circuit compliance. So does that mean that they did account for, or they didn't? Because if only 4 mLs going to their lungs, then that means that they didn't account for circuit.
Correct. Yeah, and you'll see the orange box around your volumes if you are compensating for the circuit volume. And you don't see the orange box. So that means they're not compensating for the volume in the circuit. I asked them why a few years back, and they said the volumes are so small, it's hard to set their alarms for such a tiny amount of minute volume.
That's a cop-out.
Yeah.
Oh, okay. Because the volumes are already just so wrong. So, okay, the alarms are scary, so, okay, all right.
Yeah.
.5 for a lower. Six.
6 liters.
Yeah.
Like, when would that ever happen? Maybe putting a treatment in line and running in 6 liters a minute or something. So inspiratory time for neonates is 0.25 for your preemies, up to 0.4 for your full gestation neonates. And I was surprised at Jody when I was visiting you. Most of the ventilators were set with a 0.4 second I time.
Yeah.
And that's different than years past. In years past, they would put the babies in pressure support, let them breathe spontaneously, and they would watch their I times. And whatever their spontaneous I times were, that's what they would set on the ventilator. So why they've extended it to 0.4 seconds, I don't know, unless it's because of volume guarantee ending inspiration whenever the volume is met.
They're not all in that kind of mode though.
Yeah, so I don't know why they've changed, but that's how they used to do it. So that's what my slide says. Try to match patient's spontaneous inspiratory time to synchronize with the ventilator I time. So if you see that they've got like a 0.36 second I time, then that's what you set for the mandated breaths. But then again, I'm seeing 0.4 seconds. And Corinja, what were you seeing at Broward Health for the I times?
Like 0.2.
Yeah,
Oh, really?
Some of those two actually.
Oh, okay.
Something like that.
Oh, okay. So it's not everybody's on 0.4. Okay. Oh, okay. So 0.25 up to 0.4 seconds. All right, next is setting the tidal volume, which we don't, but we monitor exhale tidal volume and then adjust our inspiratory pressure to achieve it. Unless, of course, we're in volume guaranteed and the ventilator does it for us. So to get 4 to 6 mLs per kilogram, you need to be monitoring at the endotracheal tube with an inline flow sensor. If you monitor your tidal volume at the exhalation port, then you must consider compressible volume loss. And that's the volume that stays in the circuit during inspiration, but it still shows up on exhalation. So with the servo I, let me just type this in. So with the servo I and the servo U, when you're doing the pre-use check, you can say yes to compensate for compressible volume. And then this will hide the volume being exhaled that came from the circuit. So the pre-use check figures out the stretchability, what's the word I'm looking for? The compliance of the circuit. And so it knows the compliance of the circuit. When the exhaled volume comes out, it'll calculate how much of that volume was actually in the circuit, and it only reports what went into the infant's lungs. So if you say yes to compensate, you will be seeing just what went into the infant's lungs, even though you don't have a flow sensor sitting at the Y. Okay. All right, for a compressible volume in the circuit, volume loss does not need to be calculated if a sensor is measuring flow and volume at the endotube. Without a flow sensor, exhaled volume, or your VTE, may include both the tidal volume from the lungs and the volume that stayed in the tubing. So you could use that formula at the bottom of the page to actually figure out what the baby's tidal volume is. So first, you figure out the compressible volume loss. Isn't it like the weirdest thing to call the volume that stays in the circuit? Compressible volume loss. But you guys know what that means, right? We're talking about the volume in the circuit. So there's a compliance factor for the circuit that you can find after you do the pre-use check. You can go in and find out what the circuit compliance is. And then you multiply that by your delta P, and that'll tell you the volume that stayed in the circuit.
Sorry, you said the compliance factors after you finish that?
Mm-hmm. So here's an example. A 7 kilogram patient has a return tidal volume of 130 mLs. There's no flow sensor in line. The peak pressure is 30 centimeters water. The PEEP is 5 centimeters water. The compliance factor for the ventilator circuit is 2 ml per centimeter water. How much tidal volume is actually going to the patient? So I'll give you a minute to figure that out.
I got 80.
80 mLs is going to the patient?
Yes. You have to minus it to 130, right? Because with no flow sensor, you're getting both the volume going in and the volume in the tubing. So the question asks for how much is actually going in the patient. So you get the compressible volume loss minus the 130. That means, right?
Compliance factor is 2.
That's 80.
So volume loss, plus volume of the circuit.
No, I'm saying, is she saying you take the 130 and minus the 50 from it?
So how did you do it, Ms. Vicky?
I calculated the compressible volume loss, which is 2 multiplied by 25. 25 is the delta P. It gives you 50.
Okay, so we need delta P.
Yeah. 30 minus 5. It's 20.
Have 30. Minus 5. So it's 25. Times the circuit compliance is 2 mLs per centimeter of water. This is centimeters water. So centimeters water cancel and we end up with 50 mLs. In circuit. So if 50 mL stayed in the circuit, how much tidal volume actually went to the patient? The exhaled was 130. So 130 minus 50, 80 mLs went to the patient. Does that make sense? Yeah. And then let's do example number 2. The return tidal volume is 25 mLs. So it gives us the circuit compliance. Peak pressure was 20 centimeters of water. Peak was 5. Circuit compliance is 1 cc per centimeter water. So 15. So I did the delta P times the circuit compliance and I got 15 mL. So 15 mL stays in the circuit. What went into the neonate? So the total was exhaled tidal volume 25 mL. So 25 mLs exhaled, subtract what stayed in the circuit, 15 mLs. And then the rest went into the infant's lungs, so the infant got 10 mLs. Sound good? Now you know. You are given an order to ventilate a neonate by selecting peak pressures to achieve a tidal volume of 4 mLs per kilogram up to 6 mLs per kilogram. The infant weighs 1,200 grams. What should the tidal volume be? So first thing you have to do is convert grams to kilograms because that's what the units are. How do you do that?
Divided by 1,000.
Very good. So 1.2 kilograms. Okay. So of course, we can't do parts of an ml when we're ventilating. So we would round that to what, 5 ml up to 7 ml?
Yeah.
If the ventilator measures uncompensated volume at the exhalation sensor, predict what you should expect for the return tidal volume digital readout. The circuit compliance is 1 cc per centimeter water. The delta P is 18 centimeters of water. I guess it's example 3. Whoops, went the wrong way. All right, so we had 5 to 7 mLs for our tidal volume. So let's use 7 mLs as our tidal volume. And then we need to add what stayed in the circuit. What stays in the circuit? Delta P is 18 and the compliance is 1. What's 18 times 1? Okay, so 18 mLs stayed in the circuit. So we want a 7 ml tidal volume, plus we get the return of what stayed in the circuit. So 18 plus 7. Yes, we would expect to see 25 mLs as our returned tidal volume. And then it asks if the ventilator measures volume at the Y, what would you expect for the returned tidal volume? Very good. So if you're measuring right here, you're only going to get the volume that's going in and out of the lungs. So you would see 7 mLs. For PEEP, we know that it increases our FRC, keeps the alveoli open, oxygenation improves with PEEP. For neonates, it says 4 to 7 centimeters of water. And I've seen that change over time where when you put the baby on the ventilator, you start with 5 of PEEP, just like you do with the adults. And then again, I'll ask my neonatal rotation students, did you see any PEEP less than 5? Was only 5 and up? Okay. All right. So 4 to 7, you'll see with the NBRC review. But in the hospitals around here, I'm only seeing 5 of PEEP and higher. Or 5 to 7, I should say. With having the positive pressure breaths, PEEP, all of that contributes to mean airway pressure. Do you remember mean airway pressure from mechanical ventilation? Mean airway pressure is a combination of all the positive pressures, whether it's a peak pressure from a breath, a bunch of peak pressures from a bunch of breaths, PEEP, all of that gets included. And then the ventilator averages all of that out and comes up with a mean airway pressure. So when you're monitoring mean airway pressure, it's safest for the lungs if the mean airway pressure is around 12 centimeters of water or less. So in monitoring mean airway pressure, it is safest for the lungs if the mean airway pressure is 12 centimeters water or less. And having external oxygen analyzers was always at every infant's bedside. Not with adults, we don't see it done, but with infants, there was always an oxygen analyzer at every ventilator. Well, ventilators now come with oxygen analyzers internally. So not only is there a little blender in there that blends the oxygen and air to give you a percentage of oxygen, there's also a sensor to make sure that that blender is doing its job and giving you the correct FiO2. So it's being blended and it's being analyzed inside the ventilator. Question?
The only vent that I've seen in the oxygen analyzer is the high frequency oscillation.
Yeah.
Everything else has its own.
Yeah, that's true. So the oscillator does not have an internal oxygen analyzer. Thank you for that. Keep SpO2s for preemies at. Very good. What did I do?
Flip the page.
Did I tell you 92 or 95? Okay. For setting sensitivity, the ventilators have the same sensitivity choices for neonates as it does for adults. So you have your flow by sensitivity, your pressure sensitivity. Flow by is still more sensitive than a pressure change for initiating a breath from the ventilator. And having the flow sensor in line and measuring flow right at the Y is also considered more sensitive than measuring at the exhalation valve. I don't know, the sales reps told me that there's really no difference. But the intensivists want it measured at the Y, so that's why they always have the flow sensor in line. Another way to measure inspiration occurring is having the esophageal pressure sensor or the EDI catheter in and having the NAVA cable connected. So that is another way of measuring sensitivity. And with NAVA, the ventilator looks for the diaphragmatic activity to increase, and that'll initiate a breath. So the EDI trigger can initiate a breath. Oh, you guys have a test on that tomorrow, don't you?
Yes. This is the part where everything just starts merging.
Yeah, it's true. Did you?
So does the EDI catheter go in the stomach, or does it go a little bit above the stomach? 'Cause I've heard in your PowerPoint it says the stomach, but I've heard just a little bit like above the stomach too.
Oh, like it's sitting in the esophagus and not in the stomach?
So is it the stomach or is it?
I was taught that it's in the stomach. Yeah.
Because doesn't it sense diaphragmatic movement? Yeah, so it'd have to be in there.
It's like where the gastric bubble is in your stomach, isn't it? Like right at the very beginning of your stomach.
Mm-hmm.
You can see on the X-ray.
Yeah, and can food be delivered via the EDI catheter?
Yeah.
So it's got to be in the stomach, right? You can't put the food in the esophagus because it'll come up into the throat. So what about that leak around the cuffless endo tube? Oh, it's time for a break. So I'll tell you guys after break. Okay, so what the Zoom doesn't see is that I wrote some stuff on the whiteboard. So your fellow classmates will take a picture of it and then post it so you guys can see it. And now I'm going to explain it. So when we're looking at a hysteresis curve, we're looking at pressure and volume for one breath. So having pressure control, what's different with this hysteresis curve from what you're used to seeing is instead of it looking like a football, it's got a flat part on the right side. So this is flat, and the reason that it's flat is because pressure stays constant throughout inspiration. So a hysteresis curve and a pressure control mode and PRVC mode, it's going to have a flat side to it because pressure is staying constant throughout inspiration.
So the only time it has that curve
Football?
and volume.
Yes.
Okay.
Yeah, that football look is a volume mode of ventilation.
Mhm.
Yes.
Okay.
So one thing in neonatal ICU is the intensivist, the respiratory therapist pay attention to what the hysteresis curve looks like. And they notice that if it's getting more flat, they assume that the baby needs surfactant. So it took me a while to put things together to figure out what the heck are they talking about if it gets more flat. So then I realized with looking at the hysteresis curve, when the volumes are diminishing, because in a pressure mode of ventilation, if your lungs get stiff, you know how volume goes down. So stiffer lungs, lower volumes, make the curve look more flat. So that's what I have at the bottom.
So the third one would be the stiffer of the one.
Yeah, so here with a peak pressure of 25 centimeters of water, you're getting a 30 ml tidal volume. Here with 25 centimeters water for your peak pressure, you're only getting about 20 ml tidal volume. And then here with your peak pressure of 25 centimeters of water, you're only getting about 15 mLs for the tidal volume.
So that means that would indicate that the lungs are becoming stiffer.
Yes. So when they see that, the graph looks like it's lying down more, they assume that the baby needs surfactant. So the missing part to that statement is with the peak pressure the same, volumes are less. Volumes are less because the lungs are stiffer. The lungs are stiffer because the baby needs surfactant. So that was the missing part that it took me quite a while to understand why they kept talking about the hysteresis curve is flat, the baby needs surfactant. And it drove me crazy for the longest time, and now I know. It gets flat in pressure control modes. Doesn't get flat in volume. When we're that original hysteresis curve that I showed you. Sorry.
The volume is stiffer because the baby needs more surfactant.
The lungs are stiffer because the baby needs more surfactant.
So this is just like initially right after they're born or taken out from a C-section. Or could that be like, say they've been a preemie for like, or a neonate for like 2 months now in the NICU?
Yeah, will they give surfactant after 2 months? No. So is it somebody with an earlier admission?
Yeah.
Yes.
Okay.
Okay, that was my question. I was holding that in my pocket since Friday. So surfactant is given like within first dose is given like kind of right after birth. And then the second dose after 12 hours or something like that, right?
Yeah.
But then what if 2 or 3 days later, they still need more? Can it be given at 2?
Do they max out at a certain dose? I wonder. I don't know the answer to that.
Or my next question, what if it's not given immediately after birth? Can it be given 2 or 3 days, two or 3 days after birth?
So
Is there like a time for when we put it on?
I had that one patient, I did my.
What a letter
I
of
don't know.
question.
I don't know.
So 2 or 3 days later, does that, or 5 days later, or weeks later, is there a cutoff period for when surfactant?
So no cutoff period, but if there's a lack of surfactant in the lungs, it's not going to take 5 days to figure that out.
Okay,
Going back to this question, and kind of my question too, because that one baby I did my report on for you. She was born in the beginning of August and then in September extubated, self-extubated. And then they gave her another dose of surfactant in September when they re.
Oh, really? Oh,
So
my
that's why I
word.
was curious too, so
Yeah. So
like over a month.
and they look at the x-ray and they see a lot of atelectasis. Maybe they decide, okay, let's get some surfactant. Okay.
that makes sense.
Augusto, hi.
Good morning. How are you?
Good, thank you. It's not time for inventory yet, is it?
No, just we're looking for the Perkins grant,
All the Perkins grant stuff?
just the new ones.
Do you know what they are?
I send you the report. So this one, be there.
Hmm. It's the AV trach, I can show you where that is. Breathing, oh well. Internal and
No, this one is for the.
Oh,
It's two.
okay, so yeah, I saw the trach back there, but I don't know what this. I wonder if that's our caucuses. So you have a key to open the door? Okay. Hold on, guys, I'll be right back. Next time, who's got all the units of the-
Huh? Are you on Zoom?
No.
Right. Are you on Zoom?
Huh?
Are you on Zoom? You want,
Yeah.
is she recording? I don't remember, it says.
If you have any more questions, then I'm gonna-
On the speed.
I was-
Do you remember that
Still the one that-
flash drive I gave you? Which semester is that?
I just don't like snow. Somebody's on the fence and maybe not. It's just-
Is it pharmacology or the first?
It was for the spring semester. Just generally started January.
So, is that when you were taking pharmacology and stuff? Can I see that next time? Just because I lost mine like an idiot, so I'm gonna make another one.
Alright, I didn't have the.
Just whenever you can,
You guys are carefully.
unless you lost.
I'm gonna look for it.
All right, so the PowerPoint, are we finished with the hysteresis curve and understanding why in pressure control it gets flatter as the lungs get stiffer?
Yes.
Okay,
Less compliant, right?
yeah, less compliant, less volume in a pressure mode. All right, so now we're going to talk about the leak around the cuffless endotube. So that's a big difference with neonates having a cuffless endotube. We always have a leak around the endotube. The leak can be bigger if the tube is too small for their trachea. And then it can be less if the tube is occupying a large enough spot, but there's always going to be some sort of a leak. So will volume loss occur? The answer is yes. And how do we know that we're losing volume?
Volume waveform, is it? It kind of has like a flat. Development at the bottom, it's not completely, it doesn't touch baseline.
Very good. So your volume time graphic doesn't go back to baseline. What else? How do we know we're missing volume? Slow volume loop, yes.
VTE.
Very good. So looking at VTI compared to VTE. If the volume delivered by the ventilator, it measures the amount of volume it's sending into the lungs, and then it measures the amount coming back from the lungs. And if some volume escaped around the endotube or there's a leak in the circuit, it doesn't get back to the exhalation port, and then the ventilator reports it as missing volume. Yes.
You know how like for adults, it's less than 50 milliliters, right, for difference?
Mhm.
Is there like an guesstimated range for babies or no?
No, and then the servo ventilators in the AVIA monitor the percentage of air that's leaking around the tube. And when it gets to be more than 30% leak, it's time for a larger endotube. All right, does having a leak affect trigger sensitivity? And the answer is yes, it can cause auto triggering. And then the next question, can pressure support breaths end if there is a continuous leak? And if it's a large enough leak and flow doesn't diminish, then inspiration doesn't end. Yeah,
But I thought it a certain kind of volume of the entire volume of the river. Previous slides. It ended up-
Pressure diminishes this when. Pressure support breath ends.
Yeah, I know, but I think I'm getting.
Get a volume there.
Yeah, that's what I'm thinking of. Never mind.
Okay, what about after the 5 seconds? If it doesn't end, then after 5 seconds, we just. end back.
oh, that's true too.
Oh, okay.
Yeah. So if flow doesn't diminish, the pressure support breath doesn't end. The vent will end the breath after 5 seconds of inspiration, and that's the default of the ventilator. Do you know what default means? Like it's preset,
Yeah.
things that are preset. So if you're seeing a long inspiration, that's one of the things you're going to question in your mind. Wow, how come this inspiration is so long? I expect like a fourth of 0.4 seconds or 0.5 seconds. Why is this inspiration so long? And that'll be your clue that your pressure support breaths are not ending because the flow is not diminishing. It just keeps leaking and leaking, and now it doesn't diminish.
Awesome.
Yes,
So is that when you're going to increase your flow cycle off?
perfect. Yes. So you will need to increase your flow cycle offsetting to a higher percentage. And greater than a 30% leak, we need to re-intubate with a larger endo tube. So if the leak around the endo tube is more than 30%, intubate with a larger endo tube. Everybody got that?
And Professor, it says you need to increase the flow cycle offsetting to a.
Higher percentage. Asynchronous ventilation, we know, is like if inspiration isn't sensed by the ventilator, so the baby breathes in, the ventilator doesn't recognize that. Asynchronous ventilation is when the baby's exhaling, but the I time is too long and it's not matching up with their inspiratory efforts. If pressure support breath doesn't end when it's supposed to end, sensitivity, all of those things cause an increase in work of breathing for the neonate. So it says it'll cause the neonate to have to exhale against the machine breath, have an increased work of breathing. This can lead to an increase in intraventricular hemorrhage. How they correlated the two, I'm not sure. So. And the baby might need to be sedated more and paralyzed more only because they're not synchronous with the ventilator. But we don't expect them to be synchronous with the ventilator. We expect the ventilator to be synchronous with them. So it's making those little adjustments to help out. Can we use an HME to humidify a neonate's bypassed upper airway? And it answers the question for us. We know that using an HME increases dead space because the HME has to go between the Y and the endotube. So the air inside the HME gets rebreathed. That's not good. Water retention capability, it's only as good as about 80% relative humidity at body temperature. So an HME doesn't do as good of a job as a heated humidifier. There's a leak around the endotracheal tube, and that means you're losing heat and you're losing moisture that doesn't get replenished. And there's an increase in airway resistance when we use HMEs. So babies that have a body weight less than 5 pounds, or is it 6 pounds? Don't use an HME. You want to use heated humidification only. How does placing a small volume nebulizer treatment in line with the ventilator circuit using additional flow from a flow meter affect neonatal ventilation? Whew, that's a long question. So when you put a nebulizer treatment in line, and then you hook up your oxygen tubing to a flow meter, you turn on the flow meter, and now you're adding extra flow into the circuit. Does that mess things up?
Yes.
Yeah, especially if you're in like volume modes, PRVC, it's going to make the tidal volume bigger, right? By over 100 mLs. So to do that to a baby, that's going to cause hopefully the high pressure limit goes off, because how do you add 100 mLs to little baby's lungs? Pediatrics, again, that's a lot of volume trauma. So with adults, adding 100 mLs to a 400 mL tidal volume, not a big deal for 10 minutes or whatever it takes to run the treatment. Our best bet is using the AeroNeb, because with the AeroNeb, you're not adding any extra flow. You don't have to change your alarms. Your tidal volumes doesn't get any bigger. FiO2 doesn't change. Nothing changes. So AeroNeb is the way to go. So you should see AeroNeb used in all the pediatric areas and the neonatal areas. If you don't, and you see where you have to run the nebulizer by using an external flow, remember to turn down your set tidal volume if you're not in a pressure mode. If you are in a pressure mode, do you have to do anything? Will the tidal volume get bigger in a pressure mode? No. So if you're in a pressure mode, the ventilator will still only keep that same pressure in the lungs. The tidal volume won't get any bigger.
The volume of air is the only thing you probably have to do is change your alarm setting, right?
Yeah, that's true, because now you're adding extra minute volume.
Right.
Yes. Very good. So is this something you guys already know? Do you want me to rewrite it? Okay, there's silence. Okay.
starting to see a lot of air lamps now too.
Where?
Everywhere, like especially there's a lot of patients have it, but I think only one patient I gave treatment to actually next to the SVN. But everybody else had it.
So you're still seeing SVNs being used with the adults or
Regional. is SVN.
Yes.
with
Really?
adults?
Right,
Yeah,
mostly Memorial West is not everything is aero.
Really?
The Aerogen is pretty.
Airgen is good though.
You just.
It really is.
you
It
just
really
put
is.
the meds in, you hit the button and you walk away and then go, that's it, like.
But it's even more than that. The particle size is so small
So
and
better
the particle is so
composition.
stable. I just get really excited about that.
Doesn't mess with the cell line.
Right, yeah.
I think they're a little more expensive though, but
Yes, that's true. You can tell that we're not in the financial end of things at the hospital. All we know is the best equipment.
I agree.
In the long run. It's time saver, it's safer, probably costs us.
And you don't have to break the circuit.
So in the previous, for the notes, I said in volume modes of ventilation, you have to turn down the set tidal volume. In volume guarantee, you have to do the same thing. Can you add that to your notes, even though I'm on the next slide now?
It's for the page we were just on.
Yeah,
Can you repeat it?
yeah. So when you're adding an external flow to run the nebulizer, you have to turn down your tidal volume if you're in volume guarantee. The only thing I gave you on the list was volume modes, PRVC, and I didn't mention volume guarantee. So add volume guarantee to that list. So if you're in TCPL volume guarantee and you want to run a treatment with an external flow, you still have to turn down your tidal volume, the tidal volume setting. All right, so now we go into scenarios. An 1,800 gram infant was born at 34 weeks gestation. Vital signs show a heart rate 150 per minute, respiratory rate 62 per minute, SpO2 85%. The infant showed mild retractions and mild grunting. So what do you think? 34 weeks, that's premature, right? It's not our 24-weeker, but it's still premature. We're seeing mild retractions and mild grunting.
that'd be a late term freebie, right?
A late term preemie, yeah. But what could be happening? Like not knowing anything else, just getting that information, premature, mild retractions, grunting,
Surfactant.
lack of surfactant. Very good. So keep that in your mind. ABGs were drawn, shows a pH 7.30, PCO2 is 48, PaO2 52, bicarb is 22 with a -4 base. What are you noticing about the blood gas? Okay, so respiratory acidosis, uncompensated, and does it say room air? It's not saying room air.
I was just thinking one too.
So we just have to go with the information we have. 52 PaO2, it's still a little low. If we want 55 to 70. What would you recommend?
We'll see that.
Okay, and what are your thoughts?
Well, it doesn't seem like they need to be necessarily intubated because they're not like struggling. I mean, they're struggling, but they don't seem to be struggling that hard. They have a good SpO2. The respiratory is a little bit high, so maybe they just need some help working on their breathing. Because their pH isn't that bad either. It's low, but it's not like it's just under threshold for low. You know what I mean? So
Mhm.
That's.
Very good.
Maybe
Brenda?
nasal CPAP, with maybe 5 centimeters of water, just to open up that alveoli.
Okay,
Yeah, they just need a little bit of support.
Or non-invasive pressure.
okay. Tidjin, 1 second, someone.
I'll give you just give her that.
You're thinking automatically give surfactant? What if all they need is a little bit of nasal CPAP? Wouldn't you want to try that first?
It's a good surfactant, you have to intubate.
So non-invasive first.
Non-invasive first? If it
Well, also-
doesn't work, then
Isn't
yes.
it 34 weeks, they should have more like surfactant development by 34 weeks and a 24 week reduction.
Mhm.
Mature lungs.
So. they
Summer,
probably
what were
just
you
need
going to say?
Same thing.
Okay, so you thought, we know that we're lacking some surfactant here. Let's just skip to the chase and give some surfactant.
Yeah, but it makes sense for me.
Yeah, so giving a little nasal CPAP first, and then we may still have to.
You better try non-invasive.
Is it possible to give nasal CPAP via the ventilator?
Yeah.
Okay. What's another setup we could use beside the ventilator?
Or not the jet. What is it? What was the one we had in class that I always did the jet?
Ventilation.
Oh, the bubble.
What is it called?
The bubble seat.
Yes, very good. So another choice would be bubble CPAP, where you stick the column into the water and they exhale against a column of water and that creates bubbles. It creates positive pressure. You saw bubble CPAP on Friday? Oh, good, okay.
I remember from that.
Yeah, if you can take a picture of the setup, like ask permission first, I would love to be able to add it to the lecture notes. The infant was placed on bubble CPAP via nasal prongs, +5 of CPAP, 25% for the FiO2. O2 sat 84%. Well, we're losing ground here. 2 hours later, grunting worsened. The infant was in obvious distress. FiO2 had to be increased up to 40% to maintain an SpO2 of 85%. Do you think we should do what Tidjin said at this point?
Yeah. That's
Okay.
fine.
This doesn't hurt to do these with, or the.
Okay.
non-invasive first, right?
Yeah, so I guess we need some Curacert. The infant was sedated, paralyzed, intubated with a 3 millimeter cuffless endotube, ventilated in TCPL to achieve a tidal volume 4 to 6 mLs per kilo, rate of 40 per minute, 40% for a P by time 0.3 seconds. During the procedure of delivering the surfactant, the saturation fell to 80%, but improved shortly after. Why would our O2 sats fall during delivery?
Because you're including the airway with the Curacert, so it's gonna make you drop in sat, and then it's gonna open up the airway, and you're gonna reset really fast.
Perfect. Yeah, so that Curacert is really thick. As it's making its way to the alveoli, it does plug up the conducting airways, and O2 sats fall. But then once it reaches the alveoli and disperses through the alveoli, then O2 saturation improves. There was no pneumothorax. It's a good thing because a rapid change in compliance can cause a pneumothorax.
So now you can extubate them then.
Okay. Very good. Does everybody agree? We got the surfactant in. Should we check anything before we extubate?
Or,
An EBG
yeah, that would.
and chest X-ray? Very good. So you would recommend an ABG and a chest X-ray. 1 hour after surfactant delivery on the same setting, 734 pH, CO2 is 40, PaO2 is 90. 21 bicarb with a -5 base, saturation 97%. FiO2 was weaned. 1 hour later, the infant was extubated and placed on bubble CPAP. How come we didn't keep the 90 PaO2? Isn't that a good PaO2?
Yeah, 88 to 92.
Is there 100% saturation of that? They're over, you don't want them oversaturated at 97.
Why?
ROP.
Very good. So we're concerned about the PaO2 being high because it can damage the eyes. Remember, with that high of a PaO2 will start those blood vessels in the back of the eye proliferating. So we're concerned about that high PaO2. Corinja, were you saying something? Here's another scenario. An infant was born at full term, weighing 3,200 grams. Lung development is normal. The infant went to the OR because of bowel obstruction. She was returned to the neonatal ICU, sedated and paralyzed. So she's going to need a ventilator until her sedation wears off. So what settings would you place her on? She's full term, healthy weight, lung development is normal. She just needs to be on the vent until she wakes up.
Does she have to be on a conventional vent or can she be on like an oscillator?
An oscillator is when for failure of conventional ventilation, it's if you're using high FiO2 and PEEP,
Okay.
or if you have a huge leak,
I was. for-
bronchopleural fistula.
So for after a bowel obstruction or any kind of surgery though, you would want like low volume, so wouldn't you? Just get that affected?
Why not a normal tidal volume?
No, that's.
Low pressures, right?
That one like 20.
Cause she just had a fall, she has a fall obstruction, so you want low pressures for her. right?
I would think.
What's the connection?
That's why I'm confused.
Um,
See, because I was
the
thinking that
problem,
too,
that's
and I'm
what
like, would it be low pressure or the volume or? Would you want both just to be kind of lowered? Because you don't want to put any. Pressure on any. area of it.
I see. So you're thinking, okay, abdominal surgery. We don't want to put pressure on the abdomen because of the surgery.
Yeah.
No, I don't think that way.
Okay,
Isn't that when we do permissive hypercapnia?
No. No, so it's okay to ventilate lungs that have had, that are sitting above abdominal surgery. Yeah, so you don't have to keep tiny tidal volumes. You could still use your 4 to 6 mLs per kilogram after abdominal surgery.
sorry, I confused everyone.
No, everybody was thinking the same way. 20?
I think it don't, right?
TCPL.
Okay, so TCPL. 3,200 grams. Do you want to start with a pressure or do you want to go volume guarantee or what? TCPL volume guarantee? Give me a title. Pardon me, give me a title volume. 20 mLs. Okay. What do you do for a rate?
40 is the
Okay.
minimum, you know?
Mhm. FiO2, probably somewhere close to room air, right?
30,
30, okay.
you don't want it too high, but you can also titrate it down if it's saturated low.
Very good. PEEP. Oh, we're not an SIMV, so no pressure support.
Okay, is that tidal volume a little too high though? Because when I did 3.2 times 6, I got 19. So is it just like a smidge too high?
Do 3.2 times 6. What do you get?
19.2.
Oh,
So should we put it like maybe 18 or 17? That's like a middle ground.
Okay. All right, very good. Would you recommend anything else? Okay, what else? And chest X-ray, very good. Let me know when.
You're good. Thank you.
Mhm. All right, so ABGs are drawn, chest X-ray obtained for endo-tube placement. Here's our blood gas. So this is full term, right? So we're not as concerned about a PaO2 of 95 as we were with the preemie. Because once they're 40 weeks gestational age, now they're the vasculature of the eye has already been developed, and giving extra oxygen doesn't change the blood vessels. So when the infant awakens, what would you recommend?
Yeah. That's what I was thinking.
Wean and extubate? Very good. All right, and extubating to nasal CPAP, maybe even extubating to room air if there was no lung pathology prior to surgery. It's possible that we could go right to room air. An infant was born full term weighing 3,500 grams. Meconium aspiration had occurred. The infant was received in NICU from labor and delivery, being ventilated with 100% oxygen via 3.5 millimeter endotracheal tube. Is it okay to use 100% oxygen on a newborn? That's full term?
Oh, it's full term.
Yes.
Yeah, full term is okay.
You still don't want 100% for very long.
Right. So we still know that high amounts of oxygen is toxic to the alveolar capillary membrane. So just for a short period of time, I guess, for transport. Baby's intubated. What strategy would you use to ventilate this newborn?
But, oh, you mean like.
Oh, that's
That's
right.
why, sorry.
Low pressure, high respiratory rate.
Okay,
Yeah.
why low pressure?
To avoid pneumothorax.
Very good. So with that meconium in the conducting airways, it can let air in, but it can't let air back out, and pneumothorax develops.
Yes.
So low tidal volume. And what was your other?
High respiratory
A
rate.
high respiratory rate. Okay, good. All right, and then this says start off with high FiO2 to prevent pulmonary vasoconstriction. So you can be a little more aggressive with your oxygenation. Because you want good O2 stats to keep those pulmonary vessels dilated as much as possible. What can happen with this baby is because of the meconium in their conducting airway or something happening around the time of birth caused them to release their poop. So they were probably stressed, maybe low amount of oxygen in utero, or maybe too low. Yeah, because once a low amount of oxygen in utero is one of the stressors that makes them poop. So now that can lead to pulmonary hypertension or the PPHN that we see.
Yeah.
So a lot of meconium babies end up with pulmonary hypertension. With that, we know that One thing that helps is keeping their oxygen levels in a good range. Not like, let's not give them too much oxygen. We don't want to damage the lungs. The thinking is, okay, we had meconium. We probably have pulmonary hypertension. Let's make sure they have good oxygenation because that will help to dilate the pulmonary vessels. Should I write that in the chat?
Yes, please.
Okay. So I wrote in the chat, this newborn may have pulmonary hypertension as evidenced by meconium aspiration. The goal will be to keep the oxygen levels in the good to high range to help dilate the pulmonary vessels. Good. So this shows a high respiratory rate. So TCPL, the rate of 60. Because hyperventilating also dilates the pulmonary vessels. So let me put that in the chat. So we know that hyperventilating, get the CO2 down, that's going to relax the pulmonary vessels. It's not done much anymore because there is a potential risk of a bleed, intraventricular hemorrhage from hyperventilating. So yes, it's true physiologically that hyperventilating will cause the vessels to relax, but not good because it's going to cause a brain bleed. So what would be better? How else can we dilate those pulmonary vessels? Very good. So the best bet is to use nitric oxide. Does a jet ventilator help with meconium aspiration babies? Can we keep lower ventilating pressures? So yes to the jet vent with meconium aspiration.
It also helps with pneumothorax, right?
Yes, very good.
The jet was the one that we saw the video for with the balloons in the water, where it could breathe like the air everywhere. It wasn't just leaking out of the one.
Right, yes.
It also helps enhance mucociliary clearance. I wonder if it could help get rid of the meconium.
Ah, okay. Tijin?
How does the jet help with putting aspiration?
With meconium plugging up the airways you get a lot of pneumothoraces occurring. But with using the jet vent to ventilate, you're not delivering big volumes of air. So you don't get as much air trapping behind the meconium.
But why not, I can't use the oscillator instead.
You could.
Because I was thinking like with the jet, the exhalation is passive, right? So would the oscillator be better because we're gonna make sure that that volume is being exhaled?
Oh, okay.
Yeah, actually. that's a good idea.
So that active exhalation pulling the air, that
Yes.
might pull the air from behind the trap or behind the meconium. Wow, that's a good thought. Yeah, I don't have an answer to that one, but yeah, that makes sense. I think at Broward Health, that's what they do. They use it on the meconium babies, and Joe DiMaggio uses the jet vent.
So if they're meconium, they're always gonna put them on those over conventional then, just to make it easier.
Possibly look at the chest X-ray to see if there's air trapping and hyperinflation, and then yes. So umbilical A line shows 728 pH, CO2 40. PaO2 72. Right radial artery 728 40, PaO2 is 300. It asks you which site is considered preductal.
The right.
Right.
radial artery.
Yes. And umbilical A line is postductal. And your recommendation, we already talked about it. So we would use, keep the oxygen levels good. And use jet ventilation or oscillation. So I will stop the recording, and for the people that are in the classroom, I'm going to go through the neonatal exam. So if you guys are on Zoom and you want to go through your exam with me, just email me and we'll set up a time to go through it.